And we're going to record this session for training purposes. All right, so a very good afternoon, buon pomeriggio to all surgeons, and good evening to Prof Gopal in Singapore. Welcome to the roundtable discussion on superior illumination for head and neck surgeries led by Prof Gopal. Thank you for taking your time from your busy schedules to attend this webinar on KLARO. I'm Janani from Vivo Surgical, and I'm going to be your moderator for the day. This session is co-organized by Vivo Surgical, the manufacturer of the KLARO in Vivo Surgical lighting device, as well as Medica, our authorized distributors in Italy for KLARO. Please note that the event will be recorded for training purposes, and the recording will be shared with you after the session. So the agenda for today's roundtable discussion starts with an introduction of our speaker, Prof Gopal, who will then be presenting and discussing about 4 different head and neck procedures. And we will be ending with a question and answer session. We will be muting your microphone during Prof Gopal's presentation and unmute it towards the end when we have the question and answer session. Right, so Prof Gopalakrishna Iyer is the head and senior consultant at National Cancer Center Singapore and Singapore General Hospital. He's also the head of Division of Medical Sciences at National Cancer Center Singapore and a professor at the Duke NUS Medical School with a tenure awarded in 2020. Prof Gopal has extensive experience in the surgical management of head and neck cancers and performs complex resections and reconstructions of cancers. He's involved in the robotic and endoscopic head and neck surgical program and has mentored the first ever robotic thyroidectomy in Australia in February 2012. Prof Gopal holds a PhD in molecular carcinogenesis at the University of Cambridge, as well as he has 2 head and neck surgical fellowships at Sydney Head and Neck Cancer Institute at Royal Prince Alfred Hospital in Australia and Memorial Sloan Kettering Cancer Center in New York. We are honored and grateful to have Prof Gopal here with us today. Before I pass the time on to Prof Gopal, if you have any questions during his presentation, please feel free to type it into the chat box and it will be addressed during the question and answer session. So without further ado, Prof Gopal, please.
Thanks, Janani. So I'm just going to say a few words before we show a few videos. One disclaimer, which is that I'm actually one of the co-inventors of KLARO. So in a sense, I may have a bit of a biased view. So I'm more than open to any suggestions you have for modifications or anything that you think that we could do to make this better. As you imagine, this problem started because I work in a big general hospital where not all the operating theaters are renovated at the same time. And sometimes I get pushed to a theater where the lights are not working very well. And, you know, I actually don't like headlights. I liken headlights to operating when the main surgeon is using his headphones. Nobody else can hear the music. Only the surgeon hears the music and enjoys the music, but nobody else enjoys the music. So headlights are a little bit like that. Whenever you move, immediately the spot falls somewhere else. And that's why we came up with this idea of illuminating from the inside. And that's where KLARO was actually born. I'm just going to show you a few videos and also some photographs and tell you some of the issues that we came up with in doing this. So the first video is that of a marginal mandibulectomy. This is the patient with a gum cancer that we did a marginal mandibulectomy for, a T2N0 gum cancer. And just a video to show you the different steps that we did and how we positioned the KLARO into this oral cavity. Just remember, for the next 3 videos you're about to see, I don't switch on the main operating light at all, and I don't use headlights because I find that these actually cast shadows and makes the operating field even darker than just using the KLARO alone. So, Jen, when you're ready, you can start playing the first video. So I don't know if the audio is going to work, but if it doesn't, then I'll just voice over it. As you can see here, what I've done is secured the lighting to a retractor, and I'm going in now with my angle blade and cutting into the mandible itself, as you can see in the middle video. And the video at the bottom shows the saw really coming through and pretty much taking off that segment. It's a rim mandibulectomy, so basically a portion of the mandible. And here, if you look here, you can see the lighting actually just being moved wherever you move the video to. And that allows you to kind of be quite flexible. You can actually fix this on anything else, or you can even leave it freely hanging in the oral cavity. I like to put it on an Army Navy in some instances, and in a malleable, which is the tongue retractor in some instances, depending on which methodology I use. One of the nice things about it is it's right in the cavity. And so if you have instruments that are short or that are very close to the oral cavity, you don't have an issue because you don't block the light. The light's coming from the inside. Makes it harder to video the procedure, but actually the light's actually of very good quality because of that. The next video I have is that of a segmental mandibulectomy. No, not segmental mandibulectomy, a glossectomy actually. Again, the same sort of principle applies. A glossectomy is actually even easier to apply the light to. You pick the most stable retractor, you switch off the outside lights, and you actually put it onto, say, either the Langenbeck or the Army Navy retractor, depending on which one you prefer to generally use in the operating theater. And again, I find it very useful because the light is right next to the tumor, I can define the margins very clearly. I can mark these out, measure these out, and then place my incision. So here you can see where I have made the measurements for this particular tongue cancer. And you can see me going in with my diathermy, making the first incision into the tongue. And note that all the lighting is coming from inside. There's no lights on the outside at all. One of the things that you have to bear in mind is that if you don't turn the light in the right angle, it can be quite glaring. So it's very, very important to get that light angled inwards rather than outwards. If not, it's going to shine right in your face. So, and the nice thing is it's got 2 or 3 settings, and very rarely I go to the maximum setting. Usually, see how it glares out if you don't do it properly. And you can see on the right how the whole thing comes out. I tend to use a harmonic scalpel, as you can see here on the right. It gives me a nice bloodless feel, and it allows me to dissect the tongue out really nicely. And what's really nice about that methodology is that the tongue doesn't get charred, and so the pathologist never comes back with issues with the margins. It's nice, clean margins that comes out. And that's partial glossectomy. And again, it's important in this case, the tongue keeps moving, right? So it's important to put it in a retractor that you can move around as well. So it's important to keep that retractor mobile, but always turn it inside. And you can reposition it if you want to do the reconstruction. Like for example, during the reconstruction, it can be fairly stable. So there's no need to actually take it off the retractor. You can even just place it inside the oral cavity. It's quite flexible, so you can bend it all over. One of the days that I was doing surgery for some reason, so I work in a big academic institution. So I get a lot of assistance for most of the surgeries I do. I think this was a day that I didn't get enough of an assistance. And so I didn't have very good retraction. So I actually opened the KLARO for a neck surgery to operate within the neck itself. So that's the next operation you're about to see. If you can go to the next video. And what I had to do, because I keep my incisions fairly short, is I put the KLARO into one of the retractors, and here I'm dissecting level 1A in a neck dissection. So you can see the submandibular gland on the right and level 1A dissection just in front of that. And I'm just taking that down. Again, these are home videos. These were all done during the pandemic. So you can imagine that these are all done on my iPhone. And I apologize for the quality of the videos. But the light is really bright and you can see the tissues really nicely. And you can really distinguish between the fat of the neck dissection and the muscle of the digastric tendon on the video on the right. So apart from the submandibular region, I also use this to dissect out level 2B, again, where it's a deep cavity and where sometimes I don't have enough of a retraction, I can really look and see that area really well. Under the flap, using smaller incisions with minimal assistance, it really helps with visualizing and removing the tissue out. I've not tried it too much with thyroid surgery, but I've got colleagues of mine who use it for thyroid surgery, because again, they make very small incisions and they can actually see around the corners. It's useful in the maxillectomy also to see the posterior wall, because you can put it in after you make your cuts in the beginning. And I'll show you some pictures of that after this. Okay, I think a few more photos and then we can actually have a conversation about it. Maybe Janani can show that maxillectomy images.
Sure.
So this was a case of, as you can see here, maybe go to presentation mode. Yeah. So here you can see here, there's a lesion here that I've marked out with the inner circle, and the outer circle is where I'm going to do the resection. And I've attached a KLARO to a malleable, which is retracting the tongue. And it's great because this is a fixed position. It just stays there and points up. The nice thing about this case was I was using a piezoelectric saw. And as you know, the piezoelectric saw is very short. And so the moment I put it in, no one else can, there's nothing that goes in because my hand completely blocks any light from going in. Which is why I don't have, in fact, I did do a video and the video turned out to be really bad because all you saw was a picture of my hand and not of the surgery itself. But I could really nicely cut this thing out, this whole circle out. And as you can see on the extreme right, you can see the defect after I resected this with a nice clear 1.5 centimeter margin all around and all the way through to the hard palate and through to the nasal cavity, as you can see there. In fact, if you go to the next slide, you can even use the light to trans-illuminate. So if you look, this is a different case where we did a mid-face degloving, as you can see on the bottom side. Putting the light in there trans-illuminates the area really well so that when you make your cuts, you can actually see the saw blade going through this area to do the pre-maxillectomy in this particular case. So again, the light is very useful in spaces where, again, you don't really get much light in. Or, even if you use a spotlight, you kind of always have to try and angle that in. I think that's all the cases I wanted to show today. And yes. Maybe we can just open things up for a bit of a question answer and some discussion.
Yes, we will be able to go into the Q&A session, and you could either choose to unmute your mics to ask your questions, or you can type it into the chat box and I could help you to read it as well. And you could ask the questions in Italian as well, because we have a translator from Medica, Mariana, who will be able to help us. So would you like to ask any questions?
Sì, scusate se intervengo, se qualcuno vuole fare delle domande in italiano siamo in grado di tradurre. O se qualche cosa fosse non chiaro della presentazione del professor Gopal.
Hi everybody, can we have this presentation for email?
Yes, we will send you the recording of the presentation afterwards, after the session, through email.
Thank you so much.
No worries. Would you have any questions on the presentation on any of the cases presented today? If not, I can actually start the ball rolling. Maybe I'd like to ask one question to Dr. Gopal. So prior to KLARO, which surgical margins were particularly maybe difficult to visualize while doing like the marginal mandibulectomy procedure?
Quite often the challenging margin, it tends to be the lingual plate of the mandible. So the inner surface of the teeth, right? Because you can never really see it very well. And when you want your bone cuts going through, you really want to see it come out the other side quite clearly. Retraction is great, but you can never get your light in there because light, it's in straight lines, right? So it's always that curve that's always hard to see. For cases like glossectomy and all that, in this situation, you can really see the deep margins very clearly. And again, I find that quite useful. I mean, honestly speaking, I see future iterations where we can even start playing around with the light. You can imagine if we switch the light to narrowband imaging or limited wavelengths, you can actually start visualizing the margins of the tumor versus where we're going to make those cuts. So that is a very interesting future sort of plan that we have with these lights. But at the moment, I think the clarity is pretty good. The key is not to put it at the maximum setting. Most people get it, they crank it up to the maximum power, and then you can't, it's just a bit too bright. I usually use it at the lowest setting to make my markings.
Did you use it in the lowest setting for all three of the procedures mentioned? All four of the sub-procedures, sorry.
It depends on how deep it goes. And I think one of the criticisms that we've had of the KLARO is that it's very glaring. It really can shine out. So it's very important to position it turned inwards, not to turn it outwards. If you turn it outwards, it just shines right in your eye and then you have difficulty, right? So it's important to turn it inwards as you use it. But it's so flexible, you can turn it any way you want. So it's just you understanding it and putting it to the setting that suits you the most.
Do you use always with the retractors or even alone in some?
So when I'm doing resections, quite often I tie it onto a retractor, either using a rubber band or it comes with some loops, some rubber loops as well, that they call it the infinity loop. So either one works. I like to put it, depending on the case, like in a maxillectomy, it sits on the tongue depressor. So either you use a malleable retractor or any other tongue retractor, you put it on that, it just shines up in one direction and stays that way during the whole case. When you have a very mobile operation like a glossectomy, you put it on the retractor that you can move around quite easily as well. But sometimes when we're doing the reconstruction, when we are putting the flap in and insetting the flap, we just leave it on the cheek, on the inside of the cheek, in the gingival buccal sulcus, and then we just carry on with the inset with it just lying there loosely. And that often takes care of the visualization in that setting. But depending on the case and how things are, you can imagine that, you know, the head and neck, the oral cavity is such a three-dimensional structure, you may have to modify it depending on what the lay of your case is.
What I understood is that you generally use the KLARO alone and is good enough for you for having enough light. But there are some cases in which you use just to add light to the light, because I have seen some surgeons here that use even with the headlight and the KLARO, just because the headlight have now the possibility to spread the light in some part of the cavity.
Yeah, no, I mean, it's not dogmatic. You can use it together, you can use it separately. But what I sometimes realize is people think that adding more light is good, but especially the operating theater lights, right? The operating theater lights tend to cast a shadow, and that makes things actually a little bit darker. And then when you switch off the operating light, suddenly it's like, oh my God, this is so clear. Why didn't I do this before? There are certain locations where the headlight still becomes maybe important, but again, if you know how to angle your KLARO in the oral cavity, it's still really.
What I sure believe is that if you are looking in the long term, it's more safe for your eyes, because I do remember when as you see, I am a little bit old and expert. In the past, we use a lot of light of the surgical lights and increase the light to have enough light into the cavity. But the problem was the access of the light. Since the access of the light is mined outside, then inside to the wound, the problem is the reflection is very high for your eyes. And so we have now all the surgeons that suffer from really high level of problem in the eyes, just due to the fact that you don't combine and you have no uniformity in the light.
Yeah, no, I do agree with that. And if you work in an academic center, you have residents, you have fellows, you have students, and everybody's head just leans in and, you know, just makes it worse.
But probably is the scare not seeing enough. That's it.
I think that fear exists, but it's like laparoscopic surgery, right? When you do laparoscopic surgery, I think the early days of laparoscopic surgery, everyone did the operation with the lights on and not with just focusing on the TV. But as you know, now it is almost a standard thing that you do not switch on the operating lights once you put your scopes in, because it actually makes it more difficult to see the screen, the monitor, as you do laparoscopic surgery. So I think there's an analogy.
For instance, what they use is they use a blue light, very soft one, because it do not interfere with the others.
That's true. Yep.
Are there any other questions from the ground?
So one of the things was when we started doing this, one of the other groups that came in and was very interested in this were the pelvic surgeons. And because as you can imagine, the pelvis is another deep cavity. And again, this has the flexibility to be attached to any retractor. And so the pelvic surgeons also found this quite useful to reach in those cavities. And I hear now of hepatobiliary surgeons using this because, again, in the subdiaphragmatic region, it is easier to reach in terms of light with this. Because again, you can place the light right into the cavity where you're operating.
Are there maybe just off the top of my head, any other specialties do you think KLARO would benefit most from?
I mean, I think that certainly anybody who does any work in the field, you can imagine, you know, in a military or combat zone or in humanitarian missions, you don't rely on operating lights, you don't rely on other lights, right? And this becomes a really useful tool because you can imagine that it's a small thing, you just bring it with you, it illuminates, you can do whatever surgery you want, and then and that's it. It comes with its own battery pack. So you're not reliant on any other systems or any other sources of energy to visualize things. So that's one general area where I think it's very useful. In a hospital where they haven't renovated the lights very efficiently or very often, like, you know, I work in SGH, which is one of the best hospitals in the world, and I can tell you that about a third of the operating rooms don't have good lighting. And the reason is because they're slowly going through to renovate it, but you know, it hasn't been done yet. And so again, you need some other alternative sources of lighting in that situation. Are there any other deep cavity? I would imagine this would be useful.
Dr. Gopal, we have a question.
Yep.
They would like to know if in the neck surgery, the light that refracts back from the cavity will bother your vision.
Yeah, so I agree that if you don't turn it the right way, or you don't place it facing inwards, there is that possibility. In that oral cavity, you can imagine that you can tuck it under the buccal cavity or under the oral cavity so that it reflects inwards, right? If you don't do that and you turn it outwards, this whole thing glares and to the front and right into your eyes. So in the neck, unless you have a skin flap and you hide it under the skin flap, it would reflect back. So I tend to use it for like cavities, like, you know, I make a short incision and I access level 1A, or in the thyroid case, you know, when you want to go up to the superior pole, again, where you have a flap and you can hide the light under the flap. If you turn it the other way, it is very glaring. And that's one of the biggest problems with this light. It can glare right back at you if you don't place it the right way.
Vuoi che ti traduca o hai capito?
Ho capito. No, l'ho detto senza fare.
Scusa, dicevo, ho capito, però se magari traduci, penso che sia più chiaro per tutti.
La luce, questa luce ha effettivamente, Dr. Gopal, I'm translating briefly.
No problem, I understand.
Dice che è una questione di la cosa più importante è il posizionamento nelle operazioni del collo, perché se non viene posizionata genera dei grandi riflessi, per cui bisogna lavorare soprattutto principalmente sul posizionamento, per cui parla come si dice flap?
i lembi.
Grazie. Per cui lui dice che l'ideale è posizionarlo sotto un lembo in modo che illumina dove vuoi ma non fa il riflesso negli occhi mentre stai lavorando. E poi parlava delle incisioni piccole, della tiroide e soprattutto che va posizionata in modo che non faccia il riflesso negli occhi.
Sì, infatti il problema che, insomma, che abbiamo riscontrato qui è proprio questo, cioè il discorso che va a finire negli occhi. E lui
Sì.
che fa? Cioè muove la lampada finché non trova che
Lui
non
trova
fa...
un posizionamento, lui spiega che lui lavora soprattutto sul trovare il punto di posizionamento e se non lo attacca
al divaricatore,
lo posiziona in modo da non avere il riflesso negli occhi direttamente.
e di solito lo mette sotto, cioè sotto i lembi, nella parte sotto della cavità, di modo che illumini completamente tutta la cavità.
Grazie.
This was a question that they had because the doctors who tried it, they had issues with glare.
Yeah, no, I do see that that's a problem. I think different people solve it differently. I'm still learning as to what's the best position in the neck. So you can imagine that we really thought of this for the oral cavity, and in the neck, how to put it in there. There are some situations that I find it useful in. As I said, level 1A, level 2B. Sometimes after we dissect the sternomastoid and try to go deep to the sternomastoid, again, putting it in the retractor allows you to go into that cavity again. But it is very important to consciously be turning the light inwards. If you don't do that, it glares in your face. Sorry, that was a lot of things to translate.
Sì, lo dici tu? Dice che la cosa più importante è che la luce deve essere posizionata internamente e che lui dice che in ognuna di queste operazioni lui impara qualcosa di nuovo riguardo al posizionamento specifico, perché il posizionamento verso l'interno fa sì che eviti di avere il riflesso negli occhi. Parla di operazioni
del collo,
sì,
svuotamenti del collo.
Level 1A e
sì, sempre di tumore del collo.
Sono tumori del collo di cui parlava.
But do you think that is important even in the neck? Because in general, the neck, for what I know, and in general, is not so deep.
No,
and so, in general, what I have seen, the exposition is more or less affordable, and so I don't know, because that was some of your colleagues told me.
Yeah. Yeah, no, I do agree with that. The neck is pretty superficial. I think the neck is not that challenging. I don't think it's essential. And I don't think, I mean, to be honest, it wasn't developed for the neck because it was always thought of for a deep cavity. So it was only some experience that we tried and it actually did help in certain situations. But I would normally only open it for the neck when I'm also using it for the oral cavity. I wouldn't open it just to do the operation in the neck. Yeah. Unless you have no lights, and then this becomes
yes, sure. or if you have to move from your OR to another one, and
yeah, no, so there's one OR in my center which is really bad, and I know that because it's basically because that OR is predominantly a laparoscopic OR. So the surgeons who not use that OR don't care about the headlight, the operating lights. And that OR has got terrible operating lights. So if I get that OR by some unlucky chance, then I use it.
So when you have to, it's your turn.
Yeah, that's right.
So you can survive.
That's right.
Give me a second that I translate this. Quello che lui dice che principalmente è molto comodo, lui lavora in un ospedale universitario dove ci sono diverse sale, dove ha sempre intorno parecchie persone, perché ha studenti, fellows, professori, assistenti, eccetera, e dice che lo spostano spesso da una sala operatoria all'altra e si trova con situazioni di illuminazione molto diverse e certe anche non particolarmente in buono stato, e per cui il KLARO lui se lo porta dietro perché in questo modo spegne tutto e usa solo quello. Quando lo mettono nelle sale operatorie dove fanno di solito le laparoscopie, in particolare, è il momento in cui lui trova più utile averlo con sé. Anche perché dice che, specialmente anche sempre in questo contesto accademico dove lavora lui, spesso si trova con pochi assistenti e per cui, essendo così maneggevole, riesce a lavorare anche con un'assistenza minima.
I believe that Italian sounds a little bit strange for you, Professor.
No, not at all. I love the language. I've watched enough Italian movies.
Okay. Nobody else.
Oh, can I confirm that are you able to hear me?
Yes.
Ah, yes.
Oh, okay, all right. Okay, if there are no further questions, then probably we can start to wrap up, and we'll be concluding today's roundtable discussion. So after this session, if you have any questions, then please contact Stefano or Billy from Medica, and they'll be able to assist. So on behalf of Vivo Surgical, I would like to say grazie to all surgeons from Italy for joining this roundtable discussion, and Medica, our co-organizers, who definitely played an integral role in making this session possible. And we would like to extend our sincerest appreciation to Prof Gopal for taking the time to present his cases. So thank you, everyone. Have a lovely day ahead.
Thank you, Professor Gopal.
Looking forward to coming to Italy soon.
Please do
Okay,
come, we'll take you golfing.
Yes, grazie.
Grazie. Ciao,
Ciao.
arrivederci.
Ciao,
Bye.
ciao.
Thank you very much. Grazie. Ciao, ciao.
Bye bye.
Thank you.
Ma magari ci vogliamo chiedere qualche cosa? Se qualcuno non ha capito qualcosa.
No.
Ombretta, hai bisogno di... Ombretta, vuoi che io ho preso